afternoon, and welcome to the Illinois ACEs Response Collaborative webinar, Creating Healing Communities. This webinar will illustrate the link between the social determinants of health, widespread trauma, and emotional unrest and inequality in Southwest Michigan. The discussion will underscore a need for basic education on adverse childhood experiences, which can lead to changes in thinking and promote policy and practice change. Our esteemed presenters will discuss a current initiative in Southwest Michigan, which started with the Population Health Department, moved through the Hospital and Public Health Department, and into the school system. This webinar is about those creating community responses to trauma, building resilient communities, and empowering residents to be the change agents in the process. First, I'd like to introduce you to the Illinois ACEs Response Collaborative and why we exist to address and prevent adverse childhood experiences from a public health perspective. While adverse childhood experiences research emphasize how deeply trauma impacts health outcomes, it also offers a powerful lens to examine public health problems and develop solutions. The collaborative illustrates the power of systems-level cooperation to intervene in the transmission of ACEs from one generation to the next. Our many successes have been grounded in a commitment to a collective impact framework, recognizing that no single organization or sector can build community resilience alone. The collaborative fills a critical role by drawing together leaders from different groups to think more broadly about ACEs and by coordinating our varied efforts to effectively move the dial. By expanding ACEs research in Illinois from learning from effective interventions in other states and communities like Southwest Michigan today, and strengthening the relationships among the groups in our state working to address ACEs, we can develop the policies and interventions we need to reduce ACEs and combat their harmful impact on our health. You can visit Health and Medicine Policy Research Group's website for more information, including policy briefs and an environmental scan of trauma-informed programs. We'd like to thank the United Way of Metropolitan Chicago for its partnership in this collaborative and the following funders who support our critical work: the Health Federation of Philadelphia, Illinois Children's Healthcare Foundations, Crown Family Philanthropies, Polk Brothers Foundation, and the Otho S.A. Sprague Memorial Institute. During the webinar, participants will be muted, but please do use the question box on the side, and we will be keeping track of your questions throughout the program. After about 45 minutes, the speakers will end their presentation, and we'll have 15 minutes of a moderated question and answer session. After the webinar, you'll receive an email with a short survey, ways you can participate with the collaborative, links to the collaborative's website and resources, as well as a recording of the webinar and slides. On to our esteemed presenters. Dr. Lynn Todman is an author, speaker, researcher, and thought leader committed to influencing what matters to community health. Lynn's career has focused on identifying and addressing the social and economic factors that undermine the welfare of urban communities. Currently, Lynn is the Executive Director for Population Health at Lakeland Health System in St. Joseph, Michigan. In this role, Lynn is responsible for setting the strategic direction of the hospital system to improve the health of the regional population, and to reduce health disparities. Lynn is also a research affiliate at Community Innovators Laboratory in the Department of Urban Studies and Planning at the Massachusetts Institute of Technology. Lynn earned a BA from Wesley College and a Master's in City Planning and a Ph.D. in Urban and Regional Planning from the Massachusetts Institute of Technology. Lynn is a member of our Healthy Chicago 2.0 Trauma-Informed Hospital Collaborative. Dr. Elena Quintana is the Executive Director of Adler University's Institute on Public Safety and Social Justice, which is driven by a mission that challenges us to all look forward with a measure of courage and also of practicality to face inequality and the challenging social conditions in ways that are both innovative and collaborative. Dr. Quintana's work includes creating programs, research, and events that promote socially just solutions to public safety problems. She partners with community members and agencies, law enforcement, detention facility staff and inmates, as well as universities and government in an effort to implement socially just policies and practices that are beneficial to all. Dr. Quintana's interests include violence prevention, mass incarceration, reentry issues, therapeutic approaches to dealing with trauma, immigration, and methods to increase public safety in ways that are socially just. Dr. Quintana got her Ph.D. in clinical and community psychology from DePaul University. We are lucky that Elena Quintana has been a longtime member of the collaborative and a member of our steering committee, among other committees, and acts as a mentor, a well-respected mentor to the entire collaborative. Without further ado, we will pass on the presentation to our presenters.
Great. So this is Elena Quintana, and I'm hoping that everybody can hear me. I am happy to invite you on this journey that has been an exciting collaboration for Lynn and I. This work in Southwest Michigan really started with Lynn's work in the Population Health Department at Lakeland Health. And she was continued her journey in researching social determinants of health in that region. So I want to start there. So Lynn, why don't you kick us off with that?
Sure. So would you progress to the slide that starts with backdrop? Or should I just
Yes, I'm wondering, yeah, Maggie, you're doing the slides, right?
I'll start it so much. So thank you for inviting me to share what we've learned over the last of the communities that they serve. Now, the legislation, the ACA legislation, defines what should be in that CHNA and includes the definition of what constitutes health needs. And in the legislation, health needs are defined very broadly. And specifically, the legislation states that health needs of a community include the requisites for the improvement or maintenance of health status in communities at large and in parts of the communities that are served that are experiencing health disparities. So, for example, health needs in the ACA legislation can include things like the need to address financial and other barriers to accessing care, the needs related to the prevention of illness, needs required to ensure adequate nutrition, needs related to addressing the social, behavioral, and environmental factors that influence health. So essentially, health needs that are identified in the community health needs assessment may include, and actually are encouraged to include, all manner of health determinants, or what we normally call the social determinants of health. So that's where we started. Next slide, please. The legislation also calls for hospitals in their CHNA to identify and address health disparities or inequities. So the first thing that we did prior to collecting the data that we used to identify the needs was to identify those geographies in our service area that were experiencing the most problematic health outcomes. And we used age-adjusted mortality rates as a proxy for health outcomes. We used state data and mapped mortality rates by census tract to tell us which subpopulations in the hospital service area were experiencing the worst health outcomes. And you can see those areas in red are census tracts where people were experiencing roughly twice the mortality rate of the county, state, and national average. So people were dying at significantly higher rates in these 5 geographies in other parts of the county. So it told us we needed to oversample. When we did our community health needs assessment, we needed to oversample in these subpopulations to find out what was going on. These areas are inhabited by low-income rural whites, black folks in urban areas, I say urban in quotes, and Mexican migrant workers. So we sought out in doing our CHNA to really understand what was going on in those subpopulations across the hospital service area. Next slide.
And CHNA stands for Community Health Needs Assessment.
Yes, thank you. So I see we're trying. So over the course of 6 months, we conducted 56 focus groups, 57 key informed interviews. We surveyed more than 600 people. We translated the survey into Spanish. We conducted a photo voice with high school students to get input from. We got input from a little more than 1,300 people across the region on what the most urgent health needs were. This slide is the visual depiction of what we found. So we found there were 3 categories of needs. The bubbles in blue, this is a visualization of the data that was analyzed. And so the blue bubbles represent those needs that are related to health conditions. And you can see mental health was huge. I mean, we heard mental health was an issue in senior centers, you know, that provide service to people with the age of 60, to high school students, black, white, Asian, all demographics. We heard that mental health was a salient issue. We talked about high levels of anxiety and depression and stress and suicide and PTSD and substance abuse. We heard that a lot, but we also heard obesity, diabetes, and cardiovascular conditions as urgent health needs. The orange bubbles are needs that emanate from the ways in which our health system functions. So people told us we need more providers. People told us we need to address this issue of cost of care and issues around health education and information. People felt there were not, that there was not enough of good information available. And then the green bubbles reflect those environmental factors, those social determinants that people felt were undermining health outcomes. In particular, people talked about a toxic food environment and poor health behaviors. So at this point, once we had this data, I began to recall my earlier thinking about ACEs. I was first exposed to it while I was at Adler about a decade ago. And I remember thinking that they're simply another category of social determinants of health. You know, they're requisites of health. And as I read more, as this data I learned also of the ACE links, diabetes, and heart conditions, and health. So this was more that we needed to embrace and do a series of trainings. In October 2016 was the first time that she came out. Within the health system, there was a lot of training, took place. So the department that I run, the Department of Community and Wellness, was trained a couple of times. We ended staff from the health department, the public health department, to participate in that. Through Elena, we met Dr. Pat training. She made something to the tune that we really need to address the issue of secondary trauma as my colleagues go out into communities and kind of start paying more attention to ACEs and people feel freer talking about them. Some of the staff that were trained in my department have done their own training. So for instance, at Western Michigan University, where we produce most teachers in the state of Michigan, one of colleagues went and trained a couple of years in training at the university, and then we've been training public housing residents. The hospital has a joint management council, which includes all 250 people who are that training was actually part of our COMET, which means that training is, that big file for the 6 other hospital systems that comprise the clinically integrated network in Michigan. One thing of note in training the physicians is that it was really important to establish that there are causal relationships between these adverse childhood experiences and some of the disease states that concern the physicians. So that all that took place within the health system. Then the entire Marion County Health Department staff was trained, and then there was a community forum where people were exposed to the ACE narrative last fall. And then Elena came back and trained every staff person that comprises Benton Harbor area schools, which is the most troubled school district in the area and one of the most troubled in the state. It's actually involved in a partnership agreement with the state superintendent because of poor performance. So Elena trained the janitors, the teachers, the administrators, the bus drivers, all 250 people who comprise the school district. She did training in Niles Community Schools, which is the largest school district in Berrien County, and then the home visiting nurse. So there's a lot of training took place between October 16th and today. Next slide, please. So what we've seen is that there have been some changes, some interesting changes. There have been changes in conversation. So folks in my department and across the health system are curious, they're engaged. They're sharing this information with community members to help them better understand the factors underlying their own health challenges. So when we go into community settings and talk to people, it's like a light bulb goes off for many people who are actually struggling to kind of figure out why their health is challenged or why the health of others challenged. We're hearing a lot of self-disclosures, people saying, you know, I had this challenge when I was a child, and now I understand why I'm experiencing this health challenge now. You want to jump in, Elena? I hear you.
Yeah, there was definitely more breadth and depth in those trainings. So she talked about all of the trainings that were done. And so it's really just lots and lots of people, probably around 1,000 people in total, getting the first kind of taste of what the information around ACEs was. And some people took it upon themselves to learn much more. And so you'll start to see even right from the beginning of just a blanketing of this information that it's very powerful and that natural leaders begin to emerge. And so I feel like there's been some really powerful stories of transformation, and just like even the very first training that I did for Lynn's staff, which is only like about, I don't know, 25 people in the room or something, some from the health department, some community members. It was a smaller, more intimate training. But afterwards, the population health department has partnered with the hospital to do some wellness education, like blood pressure checks and stuff at a local barber shop to bring health awareness into the community. And I went along to one of these visits afterwards because I was very interested in this. And I was invited to just speak a little bit about ACEs to the people in the barber shop. And I was bowled over because the owner of the barbershop, it's just a barbershop mostly for African American men, he began to share a very powerfully about how Black men need to talk about sexual abuse that happens within the community and about how that contributes to ACEs. And it was such a natural moment of giving permission to talk about something that had been so taboo. And it was incredibly powerful because the whole conversation was normalized by this science. And that's the type of thing that kind of naturally emerges from the beginnings of this. But like another powerful example was that in one of the housing developments where a staff member on Lynn's staff works, that she was having difficulty engaging women within a public housing development. But in time, after particularly learning about adverse childhood experiences, Lynn talked about how the shame and the blame fell away and they became much more active in their own recovery and in building community and in understanding about how helping and supporting one another can help address adverse experiences within their lives and within their children's lives. And they even took part of a community center that was in the housing development. They took a room that was there and revamped it so that they could have meetings there to address anything that was going on for them. And I felt like those are just a couple of incredibly powerful examples of this just basic information's transformational effects on a community. Do you want to talk about the hospital work?
Yeah, so just a couple things real quick. Our, the HR department is very, very interested in this work, largely because we have a lot of staff that are they have their own trauma, but they're experiencing secondary trauma. And so we're looking really closely at how we become a trauma-informed health system. A physician that I work closely with was struck by this work, had heard Pat Rush speak and Elena speak, and one day with one of his patients, who, in this physician's words, presented very well, well-dressed, etc., seemed comfortably situated. At one point during this 15-minute, what was supposed to be a 15-minute consultation, asks this patient, what was your childhood like? What was your childhood like? And this patient just goes through this long, subsequent 30-minute description of the violence that his father showed toward his mother, a knife at her neck, holding her head in a sink full of water, and the physician immediately linked it. I mean, he asked the question because of his exposure to ACEs, but he began to understand the connection between childhood experiences and some of the things he was seeing in his clinical practice. So those are just a couple of examples of some of the shifts that we've seen as a result of being exposed to the ACE narrative in the literature. Next slide, please. So it so happened that in March this year, Michigan launched its own ACE initiative. Laura Porter came and was out here as well, and it took place in the state capital, Lansing, and folks from the health system, myself and some of my colleagues, folks from the health department, and folks from the Community Mental Health Authority all caravanned to Lansing to hear this material. And I am sure that the energy that was around our interest in being in Lansing was catalyzed through the work that Elena had done in the previous few months. She had primed the pump. And so once we saw this, we knew exactly what it was and kind of jumped on the bandwagon quickly and went to that meeting. Another change that has happened is that in recent weeks, I got approval for, and actually hired for a new position, a program manager for trauma-informed initiatives. And again, this is all informed by the work that I've been doing with Elena. And this person will start with community education, examining internal hospital policies and practices, and seeing if we can adapt and implement a self-healing community model. In addition, this year, myself, the head of the public health department, and the COO of the Community Mental Health Authority submitted nominations for us to be trained to go through the master training program, which we are waiting to see if we're selected as a cohort to participate in that training in the fall. So, Elena, do you want to add anything to that? I think that's, the last thing I will add to this is that about a month ago, I submitted an LOI to launch a self-healing community model in this region. And I just learned yesterday that our submission was selected to submit a full proposal. So there's a lot of energy around the ACE work in Southwest Michigan, and Elena's role has been salient and critical in that, in helping us kind of begin the conversations locally?
There's been tremendous receptivity, and the thing is that, you know, I live and work in Chicago, which is so big compared to Berrien County, and it's so exciting to work in Berrien County because it just spreads like wildfire. There's just, everyone is so excited about it, and it's so easy for the science to spread and to be discussed in lots and lots of systems simultaneously, just because people know each other. It's a much smaller space. But I do think that that hyper growth and hyper awareness has led to some of the challenges that we've seen. So can we go to the next slide to talk about those? In in the hospital, in the health department, in the schools, people knew that they had really powerful information. People were excited about it. We got tons of feedback after every single training. And using the community examples from Cowlitz County and Washington State and other locations, it was obvious that the whole, that whole communities could be changed if this science is properly implemented, right? So, but there was so much learning all at once that people had pretty unrealistic expectations about how change would come and how quickly things would happen. So, just for example, I did a lot of work in the schools, and teachers would get uncomfortable with learning the basic science. They'll be like, we already know some of this, or this is already kind of familiar. Like, I just need a few techniques that I can employ in my classroom right away that will be the answer to dealing with all these things. And the truth of the matter is that the issues within the schools are multi-layered. They deal with too few resources. There are lots of traumatized kids. In some cases, there might be an inadequate leadership structure within the school. There's a lot of turnover. There's things that that one or two trainings can't really address. And so this really leads to more of a structural conversation around how resources are allocated. And I know that we're going to talk about this more, but I can't tell you how important it is to really think about the next step is the much bigger step. The basic information is the easy thing to do. Like, for example, with the doctor that Lynn mentioned, saying, what was your childhood like? He got tons of feedback. But as Dr. Rush will tell you, she started asking that of patients and realized what an incredibly powerful question that was to find out more about people's health histories. But if you're not ready for what to do when people disclose, then there's only so much you can do for your patients. And so a much deeper understanding of trauma is definitely suggested, and a lot of it comes with walking together and getting more science, because the science is emerging all the time, every day. And it's so important for this to keep being able to be revealed gradually and continue in conversations so that we keep watering the sprouts that we want them to continue to grow, that it's not just one kind of professional development seminar you have that was very interesting and told you some things about your childhood, and then you move on and you forget about it. We need to start thinking about structural changes, creating infrastructure to support a changing vision, and bringing natural emerging leaders in to be able to drive that vision and the building of the structural changes that need to happen. So I have an example of that. It's not enough, although it's a good start, to retrain like security guards in a school system. Like, you really have to rethink allocation of resources to provide money for supports rather than suppression. Or in hospitals, it's not just enough to sensitize people to the links between trauma and health outcomes. Hospitals have fundamental decisions to make regarding the way they provide services and supports to disadvantaged people and to highly traumatized people and communities. So I want us to think a little bit more deeply about it, and that really has all to do with pacing. So next slide. This is a slide of Laura Porter from ACE Interface, and this challenge is that that we need to think about, we need to think much more deeply beyond events and patterns. When we just think about them, we don't get to the next level of change, which really creates more of the lasting changes. So I'm going to walk through, looking at this slide, one example, the one that I'm most familiar with here with my work in Chicago is around violence. So we need to address shooting and killing in our city, and one event is traumatic and horrible. I just actually got back from a community center where a 23-year-old had just been shot and killed, and it obviously has ripple effects throughout the community. It's a horrible event, and we have long-term patterns of violence in the same neighborhoods, and we have for decades. But if we don't address structural violence, we're not creating lasting change. And structural violence includes criminalization of poor Black and brown communities, school pushout, lack of economic infrastructure and employment opportunities for those most at risk of shooting and getting shot. And so in order to do this, we need to examine as a community, a city, a state, a society, what are the values and the mental models that we are employing that prioritize prison for a youth over quality education and employment. So this example is powerful, but the iceberg model of change can be used to consider change opportunities in almost any system. Next slide. So I thought a lot about the steps to systemic change beyond just getting the basic training. And so obviously the very first step is what we've been employing in Southwest Michigan, and it's the basic training and understanding for all members of a system. Like when Lynn talked about training the bus drivers, training security guards, training teachers, training administrators. We're trying to get to all of the people who come into contact with young people within the school system. But that's just the first step. The next step is really unpacking the policies, practice, and rituals of a system to examine how they affect all members of a community. We tend to find that many of these are kind of give preferential treatment to some members of community over others. And often the people that get the preferential treatment are people that are not the most traumatized. And so we need to really turn that on its head and start flagging the most services and the most supports and the most interventions for the people who need it most. And this necessitates implementing changes, questioning deeper structures, really thinking about how our resources are allocated, and facing up to difficult discussions around historical inequities. And so when you've done this deeper work, to really start implementing changes and creating these deeper changes, it's so important to build space and time to have conversations that create checks and balances to prevent the regression to the mean, like the backsliding to what most people just are used to in everyday operations. You don't want to lose all the progress that's been made to be able to have these kind of hard-fought wins around making more trauma-informed environments. Shall we go to the next slide? There's one way of doing this that I want to talk about, and I use this slide to do it. One of the things that happens is marginalization. When people are marginalized, it leads to illness. It leads to illness within that population, and you'll see this in all sorts of health disparities, like within the data that Lynn presented at the beginning. And so I always ask systems that I'm talking to think about the messages that their policies give. Do their policies promote health, or do they promote isolation and illness? And so I want you to think about all of the policies that you can think of. And like on the left-hand side, I think of policies as like greetings, right? So on the left-hand side, it says, I love you and I'm so happy to see you. And I always think of this as like babies in Finland, where their parents get a lot of time off and they get a lot of free help and services. And it's like the whole government is, and their whole nation is rising up to say, I love you and I'm so happy to see you. And on the other end of the spectrum, we have policies that are implemented that say, I will willingly work towards your demise. I think a lot about immigration policies that force people into life or death situations in unsafe situations around the globe. So when you think of this spectrum of what policies do, and you can even think, for example, I often say, like for when I'm stopped by a police officer at a traffic stop, I expect that police officer to say hi, to be, I'm like very light-skinned. He's going to come up to me, and I expect a kind of cordial response. When I have presented this to other people, particularly African Americans, they don't expect a happy response or even a neutral response. And so you can see, depending on who you are, really changes the way you experience the way that policies are promoted. And so I like to use this because until you get to a high response within this policy, a policy that kind of seems like you're at least on neutral ground, then you are promoting illness. You create health disparities by having policies that exclude and marginalize people. Next slide. So some of the lessons that we've learned are, I always think of this African proverb: if you want to go faster, go alone. If you want to go farther, go together. And you really cannot go alone with ACEs. It doesn't matter what kind of a ACE rock star you are, and I have seen the best truly and love them forever because of how much they inspire other people. But they can't do it alone. We are all in this together. And so it's so important to help people understand that this is an ultra marathon. It is not a sprint. We are trying to change the paradigm here based on emerging science that is very powerful and also can be really resulting in massive health boosts and liberation. So one person having the information is meaningless, right, for the whole community. And once you understand ACE, you start seeing complete overlaps in mistakes made in systems that unwittingly re-traumatize the most traumatized people. You see it in criminal justice. You see it in school systems. You see it in hospital systems. You see it all over the place. And these systems can be really seemingly disparate, but they are often very overlapping because hospital systems, health systems, criminal justice systems, all of those systems see lots and lots of people that have lots and lots of trauma. And so it's important for us to lean in and create these cross-disciplinary working groups in order to share our learning and the kinds of interventions that have been really meaningful. And of course, we'll know if interventions are meaningful if we select baseline measurements and indicators in order to chart the progress over time. Maggie, do you want to go to the next slide? So some of the lessons that we've learned is that buy-in at all levels is crucial. And while we all relate to them, like we have very different, we relate to ACEs and the whole ACE science, which includes neurobiology, epigenetics, resilience, as well as adverse childhood experience. But we may have such very different ideas about how to implement solutions and what solutions may even exist. Next slide. So in this example, passionate leaders can spread the vision and validate the need for large changes and allocate the resources to do so. So you need champions at the top for sure. But if you only have passionate leaders at the top, then you're not going to get the kind of holistic change that you look for systemically or in whole communities. You also need frontline service providers to own the information as their own in order to create and support community transformation. These are the people that are going to be communicating and must communicate in a very faithful way and an accurate way so that the science spreads and kind of ignites the excitement of people around the community. And then it's really crucial, as crucial as passionate leaders, you need the most marginalized people to have voice and leadership to assist in spreading the word, creating models of change, and providing a vision to help those people that have been shielded from trauma to understand the needs of those who have experienced the most trauma. Next slide. And then working with trauma-informed principles and practices in a parallel process is super important when you're dealing with systems, especially I deal a lot in violence prevention in the criminal justice system. And, you know, there you see people that are just so wrung out and tired and overly exposed to trauma. They have tons of secondary trauma. They need to address their vicarious trauma so deeply. And so it's so important, like, say, for example, we're dealing with a school. You don't just want to implement a change that benefits students. We really need to think about how do we address trauma that teachers experience, their own trauma as well as vicarious trauma. How do you address trauma that doctors as well as patients will experience? What about nurses? They have their own trauma, and then they have lots of vicarious trauma. So I'm just talking about large systems, right? And so there also needs to be a mechanism for a feedback loop for all levels of change agents to share information and talk to one another. It's so important for what happens in the housing development to get back to the leadership of the hospital, because then it allows for the proper resource allocation to take place and for the proper interventions to be developed. Last slide, and we'll be able to discuss more. It's so important to create time and space and platforms for constant discussion, not just to address internal and vicarious trauma, but also to constantly improve upon the practices, rituals, challenging beliefs, considering resource allocation, policy, and law. In various states around the United States, we've seen incredible laws come into place that have taken this ACE knowledge into consideration to great effect. One of my favorite ones is that in Washington State, custodial parents with certain kinds of infractions of the law do not go to prison anymore. Instead, if they are confined to home and they are given lots of tasks and support around parenting. And this has shown an incredible reduction in recidivism, and it also reduces intergenerational ACEs. So these are some of that's just one powerful example of what we can do when we start challenging the status quo and our own the mental models that exist now, and start thinking more deeply about how to change structures to align with powerful information and science around trauma. So that's it. Hello.
Great. Thank you, Elena and Lynn. If anyone has a question, please post that on the question pane. In the interim, I can ask, excuse our technical difficulties here, something that came up for me. I know you discussed it a few times, but I think something that you have both done very well in our example for the country, and that isn't as easy for others, is really building in community voice. And you were talking about ways that natural leaders were emerging throughout the work that you've been doing, as well as how do you, the example you gave, Elena, people in the housing development need to be talking to the doctors who are running hospitals. Can you give any other strategies about to incorporate those voices, and beyond incorporating, having those voices really lead the policy change?
Well, I don't have an immediate response to how to,
I was thinking about the Women's Leadership Council in Benton Harbor. Do you want to talk about that?
Yes, so we did establish a council of women in Benton Harbor. We picked Benton Harbor because it was one of the areas where the mortality rates were highest. And the basic idea was that if we were going to address something like mental health, we didn't want the solutions to come from the health system or the health department. We wanted them to come from the community members themselves. So we organized this group, and through over a course of 6 or so months, they decided they wanted to tackle this issue of mental health. They were exposed to the ACE work. A number of them have been exposed to the ACE work, and that kind of peppered the conversations that were had in the planning for a community dialogue around mental health, which we actually had last night. It was completely led by the women that comprised this council. One in particular organized the panel of women who talked about mental illness in their families, whether it was a child, a sibling, sometimes themselves, to start destigmatizing this issue of mental health. If you can't name it, you can't address it, right? So it's been wonderful watching this group of women take an issue that was identified in the community health needs assessment, armed with a little bit of information about ACEs, and create a community event that attracted about 70 people last night to talk about mental illness. And this is one of a series that this group of women wants to host. And so that's an example of how we kind of moved from, a document where an issue is identified and engaged the community to take leadership in coming up with a strategy to address it. The health department and me and my colleagues at the hospital provide the organizational infrastructure for it. So we try to be quiet and let them come up with the ideas and plan the intervention, so to speak, which is first talking about mental illness. And I have to say that during the course of some of the conversation last night, people didn't use the term ACEs, but certainly adverse childhood experiences were evoked in some of the conversations. So that's one example.
We can't see questions that people may have. Do you have them, Maggie?
Yep, I'm moderating. Thank you for your questions that are coming in now. One, this is kind of building on to what you just talked about. Elena's story about the spontaneous and grassroots conversations about ACEs in the barbershop and community are amazing. It would be great to hear about how lay people can be trained to initiate street-level discussions inspired by trauma research.
I think that it's getting the basic training. It is very interesting because Lynn has one staff member who pops up at every single training that she can. I think she's been to at least 5 of my trainings. And I really feel like she just tries to get as much exposure as possible. And I think that that has allowed her to do so much of the work and to really own it. And I think that just getting the information in as many ways as you can really helps you to be more well-versed and just kind of fluid with the information. So, there's lots and lots of places online, as well as the movie Paper Tigers is great. I think the movie Healing Neen is great. Healing, N-E-E-N. You can stream it for free on Vimeo. And I really think that these types of things just make this information more accessible to people who otherwise don't sit around talking about epigenetics or neurobiology and adverse childhood experiences.
I'll just add to that, and I'm sure this is a universal experience, but as my colleagues have been trained in this, they connected, well, many of them are RNs, so they connected to what they've seen in their patients over the course of their careers, like, oh my God, this makes so much sense. And then many of them, particularly the one that you're speaking of, Elena, who was, kind of came to every training that you went to, she's connecting it to her own personal experience as well as the experience of the people that she's working with in public housing. It just has real meaning, real gravitas. And so I think that in itself creates a situation where this knowledge has just self-perpetuates almost. We almost have to do nothing. We just put it out there and it takes on a life of its own.
Okay, so we have a question which is, you've both said is critical, is about the need to change a paradigm, right? So someone asks, can you provide suggestions on how to provide improvements in challenging beliefs, rituals, internal policies?
So part of it is sharing the basic knowledge. I mean, I would want to find out, like, what has everybody gotten the basic understanding? And then part of doing the basic training is also saying, are you willing to challenge? If we want to really implement this science to great effect, are we willing to challenge our beliefs and our practices? So it does take some teamwork, and it takes at least a core group of people to create a tipping point. And luckily, it doesn't take everyone, but it takes 2 or 3 energized people to really have continuing conversations with each other, constantly challenging, identifying, thinking about this stuff, and it really starts to stir up way more awareness in people that is generally welcomed over time, although it can be pretty painful and challenging at the beginning.
Great. I'm going to have one more question, and then we can wrap up. And this, I can send some additional materials out with a follow-up email, as well as some of the things that Elena and Lynn mentioned. But somebody else, is a self-healing community model being applied in areas high with pandemic trauma due to violence?
Well, I think that that all of the data that we've seen also from ACE interface that's been presented is that there's so many health factors that have been addressed by just increasing the number of people who have basic training and knowledge. So it does seem to be helpful for a lot of different things. I have not seen, for example, violence factors followed, but I have seen self-harm. So I know suicide rates have gone down, have decreased like hugely. Like in places that were 4 or 5 times the state average, they went down to below the state average in Washington State. And so that is really promising in terms of what becoming more trauma-informed can do.
Great, thank you. Okay, I think this has been a really amazing webinar, and we appreciate the expertise of both of our presenters. Here's some information if you would like to contact them directly, as well as me, Maggie Litkin at Health and Medicine Policy Research Group. I manage the Illinois ACEs Response Collaborative, and we welcome participants, and we will also put you on a list for additional training opportunities. So thank you very much for your time, and if you have any questions, please reach out.
Thank you.
Have a great day.
Thank you.
Thanks, everybody.